Good afternoon all. The hyponatremia is very common in elderly patients. Previously, 10-20 years back, we hardly see hyponatremia in a medical college. Now, per day in a general hospitals, we see 3 to 5 cases of hyponatremia. To talk on this subject, we have eminent speaker, Dr. Ashish Rajan, consultant geriatric medicine, Lisi Hospital, Kochi. Dr. Ashish Rajan is an accomplished geriatrician who completed his MD in general medicine from Government Medical College, Aurangabad, where he graduated as gold medalist in 2021. He has extensive experience in various aspects of medical care, including outpatient, inpatient, and intensive care for geriatric patients, as well as comprehensive geriatric assessments. Dr. Rajan completed a year of senior residency at the Department of Geriatrics, Government Medical College, Aurangabad. He served as state trainer under NHSRC, where he trained medical officers in elderly and palliative care. His expertise is further evidenced by his contribution to 2 geriatric handbooks, a handbook of geriatric orthopedics and the 15 geriatric syndromes, and his publications in international journals. With these words, I proudly introduce Dr. Ashish Rajan. Over to you, sir.
Thank you, sir, for that kind words. Respected chairpersons, the senior faculties, and my dear colleagues. We are moving into the last section of this wonderful GSICON conference, and the topic is hyponatremia. It's a very common electrolyte disturbance in elderly and also in all age group when we consider. So the sodium disturbance, even it is a hyponatremia or hypernatremia, it is mainly because of water imbalance or a problem with the water homeostasis. So I will be discussing some physiology before going into the main issue. In going into the water homeostasis, the total body weight, of the total body weight, 60% of the total body weight in men and 50% of the total body weight in the women, it's water. And in that, 2/3 is in the intracellular fluid, intracellular compartment, and 1/3 it's in the extracellular compartment. And in this, we can see that the extracellular compartment, the extracellular fluid compartment, the main cation is the sodium. And the fluid balance is mainly maintained between the extracellular compartment and the intracellular compartment based on the osmolarity. So the osmolarity is kept between by the help of the sodium. So moving into the next, the normal mechanism is that when there is a decrease in the extracellular fluid volume, or when there is a BP fall, or when there is an increase in the osmolarity, the hypothalamus, the osmoreceptors will get triggered and the thirst sensation will get activated. So more fluid intake will be increased. Also there will be ADH secretions from the posterior pituitary, which will cause reabsorption of the water from the collecting tubules. So this is a normal mechanism. But what happens when an aging happens in the elderly patients? The age-related decrease in the total body water. So the total body water get decreased up to 50%. Even, already in the elder, females, total body water is decreased. So in elderly females, it will be more decreased to around 45 to 40%. And the thirst mechanism also diminishes with age. And age related, there is decrease in the maximal urinary concentrating ability. There will be decreased renal mass, cortical blood flow will be decreased, the glomerular filtration rate, and the responsiveness to impaired sodium balance will also get will get affected. The ADH secretion will be normal, but there will be failure to the response of the normal responsiveness of the kidney to the ADH in elderly patients. So the normal sodium range is 135 to 145. We will say hyponatremia when the sodium level is less than 135, and it's the most common electrolyte disturbances in elderly also. So when we classify the duration, acute when it said the symptoms are happening within occurring within 48 hours, and chronic greater than 48 hours. Based on the severity, we can classify them as it's very severe when the level is below 120. 120 to 129 it's moderate, and above like 130 to 134 it's mild. Now the classification of the hyponatremia is very important. It's based on the serum osmolarity. we can only say it is a true hyponatremia only when the serum osmolarity is get decreased. When there is hyponatremia with normal serum osmolarity or when there is a high serum osmolarity, it is said to be a pseudo hyponatremia because the actual hyponatremia won't be there. The normal serum osmolarity is between 275 and 290. So we will first see what is pseudo hyponatremia. So hyponatremia with the normal serum osmolarity or high serum osmolarity. First we will see with the normal serum osmolarity. Here the serum osmolarity will be normal, but hyponatremia can be seen in the lab values. It is actually because of a lab error, because of hyperlipidemia or hyperproteinemia. So in these patients we can get the lab interprets because of the diluted sample as an hyponatremia. What is hyponatremia with high serum osmolarity? It is seen in patients with hyperglycemia, especially in hyperglycemia, where the osmotically active substances accumulates in the extracellular fluid compartment and causing the dilution of the sodium. So when there is hyperglycemia, there will be a fall in the sodium by 1.6 to 2.4 millimole. And also it is seen when there is post-TURP surgery because of the absorption of glycine or mannitol or sorbitol. So now this is the low serum osmolarity. This is known as the true hyponatremia, or it's also known as the hypotonic hyponatremia. So we can divide that based on the volume status. So volume as status we will be assessing clinically. It can be divided into hypovolemic, euvolemic or hypervolemic. So based on the volume status, hypovolemic means the total body water get decreased, but there will be a greater decrease in the total body sodium. So in that I will be going to this slide in the detail in the approach. So in shortly we can divide that into the causes as there will be renal loss, many causes are there will be extrarenal causes like vomiting, diarrhea. And when we move into the euvolemic, there will be the total body sodium will be normal, but the total body water will be increased. So the kidney will be functioning normal here, so there won't be edema. So the causes will be the glucose deficiency, hypothyroidism, SIDH is a common one, and many drugs can also be causing this euvolemic by causing SIDH. In the hypervolemic hyponatremia, we can see that total body water is increased greater than the total body sodium. It can be seen in cirrhosis, cardiac failure or in renal failure. Now SIDH is an important disorder which we need to see. It is due to the non-physiological release of the vasopressin from the posterior pituitary, or it can be because of the ectopic releases. And there will be activation of this water conservation mechanism in the absence of osmotic or any volume stimuli. Usually it is a protective mechanism, but in this disorder it will be inappropriately secreted. The patient will be euvolemic, as I said, the renal response will be normal, but the total body water will get increased and leading to a low sodium value. So the criteria for saying it as an SIDH is hypotonic, it should be true hyponatremia, that is hypotonic hyponatremia. The urine osmolarity should be greater than 100. There should not be any extracellular volume depletion, and the thyroid and adrenal function should be normal, and there should be the normal cardiac, hepatic and renal functions. So there are numerous causes for SIDH, starting from a number of malignancies which can cause the SIDH. The main ones are the cardiac, lung carcinomas, and then moving into the pulmonary causes, starting from the infections, TB, viral pneumonia, there are many causes. Moving into the CNS also, starting from the infections, meningitis, encephalitis, even the bleed in the brain, like anything, brain tumor. There are many causes for SIDH, and the important drugs are the carbamazepine, SSRI, tricyclic antidepressants, which are commonly used, especially in elderly also. So many causes for SIDH. So moving into the mechanism, actually what happens in hyponatremia, this is the initial slide which I have shown. So the extracellular compartment has the sodium. So when there is less sodium in hyponatremia, the osmolarity get decreased, and so the normal the mechanism is that the water will be shifting from low osmolarity to high osmolarity. So intracellular will be having high osmolarity, the outside osmolarity is decreased, so the water will be shifted to the intracellular compartment to maintain the osmolarity level. So what happens that the intracellular fluid will get accumulated, especially the effect will be seen in the brain, where there will be cerebral edema can occur. And let's see what are the symptoms basically with the hyponatremia. Even when we say that the asymptomatic, there will be subtle, like there will be an altered behavior or mild altered sensorium, gait imbalance will be there. And especially in elderly, it can lead to increase in fall and fracture. And as the effect of, even if it is asymptomatic, the chronic hyponatremia can have an effect on the bones, because it increases the osteoclastic activity and decreases the osteoblastic activity in the bones. So it can lead to fragile fractures. The mild to moderate symptoms include a headache, fatigue, lethargy, nausea, vomiting, disturbance, the gait disturbances, confusion, and severe symptoms include seizures, coma, respiratory arrest, and death. So moving into the approach of the hyponatremia, the first we have to calculate the osmolarity. That is very important. So we have to make it sure it is a true hyponatremia, that the osmolarity should be on the lower side. So the formula for calculating the osmolarity is 2 into sodium plus the blood urea nitrogen divided by 2.8 plus glucose divided by 18. Also there is a calculated formula for the adjusting the sodium in case of hyperglycemia also. So when it's a true hyponatremia, that the osmolarity is decreased, we can go to check the next step is urine osmolarity. If the urine osmolarity is less than 100, then it is very diluted urine which is coming. So the causes will be the primary polydyspia, that is more the psychogenic, like more the water they are drinking, like beer potomania. And tea and toast diet or tea and toast syndrome is especially seen in elderly. When the elderly people are very living alone and they are frail, and they will be only eating very little snacks, consuming some fluids mainly, deficient in protein and salt diet. So that can again lead to this type of hyponatremia. When the urine osmolarity is greater than 100, we have to move to the next step, that is assessing the volume status and the urine sodium. So here we can see this is the approach in a graphical way. Serum osmolarity, it is we can leave the other part. We have already seen when the serum osmolarity is high or normal, it is not a true hyponatremia, it's pseudo hyponatremia. Here we can see the serum osmolarity is less than 275, that is a true hyponatremia. Then we have to check for the urine osmolarity. Urine osmolarity less than 100 we have already discussed. When it's more than 100, we have to check for the volume status, that is the ECF volume status we need to check. When if the ECM volume status is hypovolemic, then we have to, next step is we have to check for the urine sodium. When the urine sodium is less than 10, it means it is an extra renal cause, because the sodium is not losing from the kidneys. Extra renal cause can be like vomiting, diarrhea, or other similar kind of dehydration or fluid loss. And greater than 20, it can be mainly the renal causes like salt wasting, including the cerebral salt wasting, diuretic use, the bicarbonuria, hypoaldosteronism, ketonuria. Moving into the euvolemic, here the main causes includes the cortisol deficiency, hypothyroidism, SIDH. And in the hypervolemic, based on the urine sodium, we can divide into, if it is less than 10, the urine sodium, then it is because of heart failure, or cirrhosis, or nephrotic syndrome. If it is urine sodium is greater than 20, it is because of the renal insufficiency. So moving into the management, if it is an acute hyponatremia, we need to actively intervene in this kind of patients. We have to treat with the 3% saline because the cerebral edema and damage can occur very rapidly. And 100 ml bolus we can give over the 20 minutes, and we can check for again the repeat sodium after about half an hour. If it is not increased, we can give another 2 boluses. And our target will be to increase 4 to 6 milliequivalents over the first 6 hours. And even that increase is enough, because it will cover the most of the symptoms. Like symptomatic improvement we will get with the 4 to 6 increase in the milliequivalent in the sodium level. And the total correction should not increase beyond the 10 ml in the first 24 hours, and in the next 24 hours we should control it to 8 milliequivalent till we reach 130. In chronic hyponatremia, we should be extremely careful while using the 3%. The mild cases we can use general measures like oral salt supplementation we can do. Also in asymptomatic cases also general measures we can do, but in severe symptoms are present, then in chronic hyponatremia we can use the 3% NaCl, but we have to very much careful about the correction, and the correction should not be increased above 8 milliequivalent, like the increase should not be greater than 8 milliequivalent per day. Because there is a very much chance in the case of a chronic hyponatremia, there is a chance for like osmotic demyelination syndrome. So this is a formula which we can use to calculate how much sodium change will be there because of an infused we are using. So I am skipping this. Okay. Now moving into the osmotic demyelination syndrome, it commonly occurs in the first 24 to 48 hours because of the rapid correction. The neurological symptoms include the flaccid quadriparesis, dysphagia, dysarthria, mutism, convulsion, locked-in syndrome. It's commonly seen in case of high-risk patients like malnutrition, hypokalemia, and alcohol-dependent patients. So in the management of the hypovolemic hyponatremia, anyway, if it is very much acute, we have to manage with 3%. If there is true volume depletion, we can use isotonic saline, and isotonic saline should not be used in edematous stage or in SIDH. The tolvaptans are contraindicated in case of hypovolemic hyponatremia. So in the management of the hypervolemic hyponatremia, it's commonly seen in congestive cardiac failure, cirrhosis. Here it will be mostly asymptomatic and it will be a chronic hyponatremia. So if it is an acute, we can use the 3% saline, but usually the mainstay will be the water restriction. The water restriction, we can use the loop diuretics, and vaptans can also be used. So the vaptans are the vasopressin V2 agonists. They are used to increase the plasma, the sodium by excretion of the water. It can be used in euvolemic, mainly in SIDH, and also in hypervolemic hyponatremia. The oral tolvaptan commonly used is the, oral vaptans which commonly used is the tolvaptan, and the IV preparation is also available, that is known as the conivaptan. The management of the SIDH, it's mainly we have to look for the cause of the SIDH, and it's usually chronic. It can, if it is coming as an acute, we have to give with 3% NaCl. Water restriction is the mainstay towards 500 or 1000 ml per day. Water restriction we have to keep. Now moving into the, before concluding, I will recent case which is admitted under our unit recently. It's a 74-year-old male, known case of COPD, admitted with cough with expectoration, breathlessness and general weakness of one week duration. On admission, the patient had clubbing and chest had rhonchi. Investigation, anemia was present, infective markers were positive. The patient had hyponatremia, and the workup clearly showed that the patient had SIDH. Like the serum osmolarity was 260, the urine osmolarity was above 500, spot sodium also was high. And we want to look for the what was the actual cause for the SIDH, and the chest X-ray actually didn't show anything significant. But because he had this was his second episode of SIDH. So we had gone for a CT, and actually he had a posterobasal, left lower zone posterobasal CA length, and actual report was he had also multiple Moni beds was also there. Because the X-ray, it was hiding behind the heart shadow, that's why we couldn't had seen it. So moving to the conclusion, the diagnosing and treating the hyponatremia in elderly is complex, careful and individualized approach should be used. We have to carefully look for the etiology and correct the causative factor, and always we have to be very careful to prevent the overcorrection. Thank you so much.
Thank you, doctor.
Yes, ma'am.
Just a very interesting topic, because we see a lot of patients with hyponatremia. I think it's one of the commonest causes of metabolic abnormality in the elderly.
Yes, ma'am.
Polypharmacy in geriatrics could be a cause for this hyponatremia.
Yes.
I always keep wondering who should treat the hyponatremia. Which branch of medicine? Invariably, it gets treated by the physician. When they hear that it is hyponatremia, it falls on the head.
Yes, ma'am. Yes, ma'am. Because as you was told in the polypharmacy, mostly the patients will be treated with a thiazide diuretics like carbamazepine, It will be hidden in, it will be a combination like a medicines, and so if we need to check into the medicines actually. So for all the hyponatremia patients, we need to check into the medicines, and we have to rule out whether there is a thiazide diuretic especially, or any kind of diuretics, or any this like carbamazepine or SSRI, which can be a causative problem. First we have to look into the medication list, and if that is there, we have to omit it. That's an important factor, ma'am.
Because most of them go home. Once
Yes.
hyponatremia is corrected, we tell them, okay, you go home and you continue the same medication.
Yes.
So they continue whatever they were on.
Yes,
It
ma'am.
would be very important to regularize their medicines.
Yes, ma'am.
Especially in the elderly.
Yes, ma'am.
Is there any question from the audience?
Dr. Rajan, as I told earlier, this hyponatremia, the incidence of hyponatremia is very common in elderly patients nowadays.
Yes.
Is there any, other than in polypharmacy, what madam told, any other reasons? For example, the global warming, could it be the cause for hyponatremia in elderly?
It can be, sir. It's actually multifactorial, because also it's related to their nutrition, if they are malnourished, or their intake is poor. So that is also a factor, sir. We need to categorize based on the approach we have to categorize it. Because if in this elderly man, he was actually very malnourished, which I have discussed the patient. Because the relatives were telling that the patient had a decreased food intake, but actually it was not an hypovolemic hyponatremia, it was an SADH. So we looked into the cause and we found out it was a malignancy. It had METs also. So we need to approach the hyponatremia in a systemic way, I think.
Two scenarios we do come across commonly. One is patient with severe hyponatremia, I mean less than 120, between 116 120 sodium, without any symptoms. Another scenario, patient with single episode of vomiting, with severe hyponatremia and altered loss of consciousness, altered behavior, everything. Why these differences?
Sir, it might be the initial one will be a chronic hyponatremia, because he will be having this for a long time, and all the brain will be get adjusted to the osmolarity difference. The second one will be an acute event, because of the vomiting, the rapid rehydration and the fluid loss had caused this one. So that is why the acute stage which has caused the more damage, like the symptoms will be more, I think. The initial one will be a chronic one. He will be having for so many days. The brain also had got time for adjusting with the osmolarity change.
How long we can give Aptans?
Sir, the studies are saying that it's only can be given up to 30 days continuously. More than 30 days, the liver issues are common. So it's better after 30 days we can take a break, I think.
Sir. Mike, please.
Yeah, thank you. I just want to share with you a couple of my experiences as
Yes,
a physician, as a student of geriatrics also. I mean, all the European textbooks say salt restriction. And you do the salt restriction in a temperate country like ours. And particularly, I do not know what are the temperatures in Kerala, because whenever I have come, I have stayed in the air-conditioned place, courtesy Ashokan family. But outside, it's quite hot. There is a sensible and insensible perspiration, because of which we keep on losing salt. And on the top of that, if the person is hypertensive, first thing is salt restriction. Moment you say salt restriction, they stop almost total salt. This becomes an issue in elderly. Secondly, by and large, elderly have a sweet tooth. They would like to take a sweet fruit, sweet thing rather than a saltish things. This leads to a lot of anorexia problem. And I have seen our elderly people after the age of 70, 75, if they have hypertension, they have additionally anorexia problems. Further constipation, other issues. I always advise them, take a small pickle, नींबू का अचार खास तौर से, because there is a understanding that नींबू का पुराना अचार जो है आयुर्वेदिक हिसाब से has a medicinal value and they accept it. So if they take a small bite of that some salt goes, their appetite improves. I think hyponatremia also may be slightly affected. Second is the SGLT2 induced. I do not know, day by day they are increasing the thing that, oh no, if earlier they used to say up to 30 EGFR you can give it safely, now they say even less than that. So pharma push is there for SGLT2 inhibitors. And SGLT2 inhibitors in elderly, particularly going out or staying in not air conditioned houses, we see lot of them coming with delirium and getting admitted in emergencies. Your views on that?
Sir, just one word to add on that, on the salt diet. I think even when in congestive cardiac failure, the salt restricted diet does not mean that we should completely avoid the salt in the diet. It only means that like extra salt we should not take, like a pickle or chips like that. But the normal diet in the day-to-day food they can handle. Like normal curries which they make, there should not be an extra salt but normal salt. What happens with the scenario is that they will not give any salt. Like they will make the curry separate, and for this elderly patient they will without the salt, and they will add later on the salt for the other family members. So that scenario they will be totally deficient in sodium.
Thank you, Dr. Ashish Rajan. Let us close this session with my co-chairperson, Dr. Gita Madam. Let me extend our sincere gratitude to the organized committee for chairing, for giving opportunity to chair this session, the last session. Thank you very much.
Thank you so much.
Thank you everyone.